let us go ahead and begin our first speaker, Amber Goodwin with the Community Justice Action Fund. Amber, I've brought you into the meeting. Would you like to test your audio? It does take a minute once I click the button.
Hi, can you hear me?
Yes, we can.
Okay, can you see me? I can see you all, but you can't. Can you see me?
Have you turned on your video?
Okay,
there
great.
You are. Beautiful.
Great. Thank you so much. And just for time parameters, we have 5 minutes. Is that correct, or do we have 10 minutes to speak? Just want to make sure.
We have 15 for both your initial comments and questions. So.
Okay, great. I was prepared for about 10 minutes, but I'm going to try and cut it down so I can actually get to the councilwoman's actually questions on some of the budgeting. So I'll stop. So hopefully we'll talk a little bit about that. But Mayor Adler, Chair Flanagan, Vice Chair Kassar, the Public Safety Committee, thank you for inviting me to speak today. I want to talk specifically about solutions to build a policy pathway to prevent gun violence in Austin. And I really want to talk about doing this in the midst of while we're all healing in the city of Austin. I am really proud to be the mayor's appointee to the Austin Gun Violence Prevention Task Force that was started last November. I sit with 10 other members as well. And part of what I want to discuss today, we will also be providing in a report in the next couple of weeks to the city council as well. Just for context, gun violence has always been a conflict resolution system in America. Shootings are up across the country, and in Austin, communities need new tools and new approaches to diagnose the problem. In the midst of COVID-19 and the summer upticks of gun violence and police violence, we need to listen to communities on the front lines of what we are calling a public health epidemic on gun violence. In Austin, law enforcement and policing actually controls most of the data, the media, and the policy responses that support a narrative that punishment many times is the goal, when in fact, many of us are asking for liberation from all forms of violence that includes police violence. I join with other public health experts in believing a healing approach centered on the community is actually the answer. I'm gonna skip over a couple of things. Today, I'm asking the Austin City Council to become solutions-oriented and implement 2 solutions rooted in community-led practices to fund peace and no more violence. Money should be divested from the police department and other criminal bodies to first fund a permanent office of violence prevention with a full-time director or chief community safety officer to coordinate citywide gun violence prevention and intervention services. Second, to invest in evidence-based programs designed to promote healing, prevent further trauma, and lay the groundwork for economic growth for Austin. The city of Austin has the opportunity to learn from cities like New York, Oakland, Dallas, New York City, Philadelphia, where community-based efforts have reduced gun violence and actually paid back into what taxpayers already pay every time someone is shot and survives or is shot and killed in the city of Austin. These evidence-based approaches will focus on prevention, intervention, and healing. One of the evidence-based models I will explain very briefly is called hospital-based interventions. Gun violence claims tens of thousands of American lives every single year, and mass killings account for less than 1% of all of the shootings that happen in America. So I want to double down on that. We many times focus not only as policymakers, but in the news on mass shootings when they account for 1% of all the shootings that happen every single year. A majority of gun violence in Austin, in particular homicides, is largely concentrated in communities of color. Gun violence is not just when someone is shot and killed, it's also when someone is shot and survived. Intensive research shows that even in the neighborhoods with the most gun violence in America, a small percentage of the people are actually inciting most of the violence. In most cities the size of Austin, less than half of 1% of a city's population is driving over 65% of the actual crime that's happening. It's a very, very small percentage of the people. Residential segregation is one of the hallmarks of structural racism, a reflection and reinforcement of structural and institutionalized racism. Many residents of Austin and continue to live in racialized and economically segregated neighborhoods, and this is part of the inequality. For decades, the police department in Austin has led to traumatizing Black and brown communities and destructive cycles of racist over-policing and under-protection. A public health perspective asks the foundational questions I would ask the city council to think about. One, where did the problem of gun violence begin? And two, how do we prevent it from occurring in the first place? While our recommendations, the recommendations I have for you today on these two issues, will require the city of Austin to invest financial resources that are already strained, the costs are actually negligible compared to the toll we are already paying for gun violence every single day. The first critical step, and I'll skip over these really quick and then get to questions, but the first critical step would be to establish an Office of Violence Prevention. This office could be very much like offices across the country. There's dozens of cities that have actual offices of violence prevention. We believe on not only the task force, but other community members that the office should either sit in association with the Department of Health or be a standalone office with a city and its own operating budget and staff. This is a best practice strategy that many cities have used across the country. This money from the city should be diverted from the APD police budget to establish the centralized Office of Prevention. The second critical step would be to implement evidence-based violence prevention strategies. I'll talk a little bit about more of those are, but I'm going to skip ahead to one in particular that I wanted to bring up today, which is a type of violence prevention that is based in hospital-based intervention, and it's called HVIPs. So these are programs that have shown the efficacy of, I can't even imagine another public health crisis that we could talk about that has been shown to dramatically reduce community-based violence and violence in cities like hospital-based intervention. This was based in a program that was started in California in 1994, and studies show that intervening at the hospital is much more likely to have an impact because young people find themselves at a crossroad. They can either choose to retaliate or transform their traumatic experience. And so the HVIP strategy really is working with public health professionals who are already doing their job, but equipping them with different trauma-informed ways to talk to people who are highest risk of committing violence or having violence against them and becoming victims. Case managers help clients access resources that will promote their safety and recovery. And studies have shown that this form of intervention actually saves hospitals and cities money by preventing future injuries, both for the patient and anybody who they would actually potentially retaliate against. Mayor and City Council, the systems in place for many people, especially who look like me in Austin, to prevent all acts of violence are just not working. We need a proactive public health approach centered in healing, survivorship, and justice, and not over-policing. We will work with other advocates and community members you will hear from today directly every single day, the people who are closest to the pain and doing this work on the ground, to better understand the exact dollar number needed. I can tell you what kind of we've been thinking about in terms of the task force, but this cause and preventing future gun violence must be contained. Thank you for inviting me here today, and I would appreciate any questions that you may have.
Any members? So, Councilmember Kassar.
Thank you, Ms. Goodwin, for everything you do and for what you've done on the task force. And you know, Austin, while it is a safe city compared to other cities, we know that in communities like parts of my district, there is a significant amount of harm, and it's where a lot of our gun violence is concentrated. Mm-hmm. And that our strategies so far have not prevented that gun violence. You know, just enforcement is not getting people the prevention that they need. So I appreciate what you brought up. Do you have numbers? This is maybe to Mayor Pro Tem's question about how much similarly sized cities or other cities are investing in things like the Hospital Violence Intervention Program or for their offices of violence prevention?
Yes, so in cities like, it's hard to compare us to New York City, so I'll try not to do that. But most cities, I think medium-sized cities, spend anywhere from about $250,000, which is woefully, I think, insignificant. But the city of Minneapolis spends about, has earmarked around $250,000 to $400,000 a year for some sort of like Office of Violence Prevention that works on gun violence. But then there are cities that spend upwards of 60, 70, 80, $100 million. And I'll just say in comparison, cost comparison, every time someone is shot and killed, there's obviously a public safety cost to that, whether it's going to taxpayers or the city. And so I'm happy to share and send over information on just what we know in terms of like when someone is shot and killed, how much that actually costs. And what we've been asking people is to think of how much the prevention would cost on the front end. And some of these programs that I will send over to you all, the cost benefit of them putting in around, I think, $1 per one of these violence intervention programs, the city actually gets back around $16 to $18. So it's a cost savings and it's adding in cost to the economic value of the city while promoting healing.
I'm curious about what is the, in your understanding, what is the work that an Office of Violence Prevention does? What is the actual work that they do?
Yeah, I have actually, that was part of what I was going to say. I will just say very quickly. So a lot of what they would do is actually coordinate a lot of the data and resources that need to understand what gun violence actually looks like in the city, and work with a lot of the intervention programs that I mentioned previously. So a lot in Milwaukee and other cities that have started offices of violence prevention, when Milwaukee started theirs in their Department of Health, they hired somebody, and I can tell you from sitting on the task force with some really wonderful people, it was really hard to actually try and come up with ideas to tell the city council and the mayor, because it wasn't our full-time job. We were getting distracted by other things, and we also, to be quite frank, we didn't have enough data and resources to actually diagnose the problem. And so I think the same way that we would diagnose an issue of health, we would want to have a centralized location that could talk to the health department, could talk to city council, could talk to the people working on domestic violence and other issues. So they centralize all the different resources and then kind of create, not kind of, they actually do create a pretty much an ecological system of how violence needs to be attacked as a disease. And so they have a system in New York, it's called the New York City Crisis Management Center. So it's a violence prevention program, but what it is doing is actually preventing crisis, and it's a management system. So it's not just one person who's kind of deciding on gun violence. They're working with all the different city agencies to make sure that everyone's on the same page about how gun violence and violence intervention can work. And then they're also working with CBOs and community-based organizations throughout the city to make sure they're evaluating the city resources that are being put into violence prevention, and also trying to figure out other ways to be more innovative, because what's been working in Oakland may not work in Austin, right? And so they do a lot of evaluation to make sure that there's efficacy between what the programs are actually saying they're doing and what they actually do.
Thank you. And to be fair to you, Ms. Goodwin, you went first, and so our future speakers now know that they don't have to say all the introductory stuff about wanting us to think about reallocating budgets or wanting. I mean, that's why we're here. So we'll give you a few extra minutes to this topic. In order, I think Councilmember Kitchen, you had your hand up, and just as a reminder, my colleagues were down. I mean, if we could keep our last few stuff to like 3 or 4 minutes, that would get us moving right along.
I'll defer to Councilmember Alter.
I think the mayor was next, and then Councilmember Alter.
Okay.
I just want to thank Ms. Goodwin for the work that she's doing on that task force and for her testimony here. And I'm looking forward. You said that there was a report that was coming out from that group here. It's real close to that.
Yeah.
The bits and pieces of that you have communicated to our office are all real exciting. Mm-hmm. And I think the recurrent theme in it, and going to the chair's question, is we need to start thinking about these things differently than we are, and how we address them differently. And having an advocate inside the system that will be doing that seems to be really helpful. That's all. Thanks.
Thank you.
Councilmember Alter.
Thank you. Ms. Goodwin, I really appreciate all your work leading the Gun Violence Prevention Task Force. We included in item 96 that we should be considering an Office of Violence Prevention, anticipating the work that would come out from the task force, and I'm really looking forward to the specific report, and I hope we also can have some additional conversations out of this meeting as well. But I wanted to ask you to dive in a little bit more to the good models, because part of charting this out, it's not enough for us to say we want to have that model and have the intention of finding ways to do that. As policymakers, we have to chart out how we get from here to there and the steps in between, so that we can have a system that's effective for Austin. So can you speak to the cities that you think are doing this well, and the cities that we should avoid, their models as well?
Sure. I will say there's basically 4 types of models, and all of this will be in the report. And I obviously want to thank you for your leadership in helping out with a lot of the gun violence initiatives. But one model that you may all have heard of that started in Boston in the 80s and 90s was called Operation Ceasefire. It actually is a heavily crime control method that has been shown to lead to mass incarceration and other forms of violence against people of color. But I can send information on that. And so that is one that heavily involves law enforcement as the first trigger to make sure that people in the community are not doing any more gun violence. Another model is called Cure Violence, and that's part of this public health ecosystem. And so it was actually started by a group of physicians. And that also is a system that, that's the New York City crisis management system that builds this ecological model that not only focuses on where the gun violence started and how can we prevent it, but also works with violence interrupters. So people, dissimilar to the hospital-based intervention, the Cure Violence method actually hires people who may have the lived experience of being a person who was a former shooter or somebody who was from the community, and they're called violence interventionists. But they also are credible messengers. They're people from the community who talk the same talk and walk the same walk and really understand the communities and can go into the communities using evidence, using data, and using their credible message and saying, we need to stop the violence. So whenever you hear a lot from cities like New York City, parts of Chicago, and San Francisco and Oakland, they're using some sort of cure violence model. And then I mentioned the hospital-based intervention. And so that's a really popular model too that was obviously started by physicians as well. But that's the first line of defense in that basis, is working and starting inside the hospitals when someone has already been a high risk because they're in the hospital system. So working with people in the hospitals to educate people. And then the last one that is a little bit more innovative and has a ton of information on it too that I'm happy to send over is called Advanced Peace. And that's a program that was started out of Richmond, California, which started one of the first offices of violence prevention. They called it the Office of Neighborhood Safety. So the mayor in Oakland and in Stockton and in Richmond both have implemented the Offices of Neighborhood Safety and have seen dramatic reductions. And so when I say dramatic reductions of gun homicides, I don't mean like 10, 15%. I mean upwards of 60% in a 3-year time period. So I would say whatever funding mechanism, it should be multi-year. We won't see results for probably the first 12 to 18 months. And then what we've seen is there's been a dramatic drop off in homicide reductions and harm and crime after about 12 months to 18 months.
Thank you. And I want to underscore a comment you made early on, that most of the gun violence situations are not the mass shootings. And so, I think this is something that the task force has looked closely at, but I just want to underscore that there are lots of different types of gun violence, and whatever we set up is going to have to be able to target what's prevalent in Austin and use what we can to really target it to the challenges we have in Austin within the frameworks that we're allowed to as a city government to address things. And so I very much support community-based violence prevention strategy and thinking about what an office like this would look like. But for my colleagues, I also want to mention that, there are also steps that we can take with respect to gun storage and public awareness that address some of the issues that are in Austin that, combined with this, I think are going to really help us to address the gun violence stuff. And I look forward to continuing to work with you, Ms. Goodman, on these issues.
Okay. I think we really got to move along. Our next topic is going to be one where there's a lot of interest. Ms. Goodwin, thank you so much for your brief time this morning. Hope you don't mind if we tap into you to participate again in the future. I'm also very interested in hospital-based interventions because, frankly, I'm wondering if Central Health might be participating in a budget sense, or Travis County might be participating in a budget sense. Councilman Chobo, were you?
Just a super quick question. Thank you, Ms. Goodman. You had talked about forwarding on some information, and I would just ask if you would forward it on to all of us. I think the examples you've offered are really exciting, and I'd love to review it as well.
And I'll make sure that everything that the task force has done, myself and 10 other folks, is in there. And we've had a couple of separate pieces that we'll also put in there. We'll make sure it gets to everybody.
Yeah, we'll make sure that any information sent to any of the committee members gets back to the clerk for distribution to the whole council. Ms. Goodwin, thank you so much. Now I'm going to. Okay, so our next topic, mental health response. I'm going to bring in Mr. Black and Mr. Hofmeister. I can find them in my list. There we go. And EJ. There we go. Okay. Okay. So mental health response. Mr. Black, your program has been on everybody's lips over the last month. So I am very interested to hear what you have to say. Why don't you go ahead and start, and then I'll have our other two speakers go.
Absolutely, and I'll try to be as brief as possible. I want to start off by thanking the council for giving me an opportunity to talk about the program just a little bit today. Andy Hofmeister, I owe you a phone call, and Greg, it's good to see you again. So rather than go into a lot of detail about kind of the CAHOOTS program, that 40,000 foot view, there were a few things that I wanted to highlight about our behavioral health first responder program. The first of those is just a recognition of where we fall in that full scope of public safety services in our community. CAHOOTS is responding to 17% of the externally generated calls that come through our communication center. So that's not just 911 or non-emergency. That's really kind of looking at the entire call volume coming through that system, being answered by the call takers. Our teams respond to all of our calls on the same priority channels as the rest of patrol in our community. That means that we are hearing every call officers go out on, which gives us opportunity to divert and respond alongside or instead of officers for those calls that haven't made it to our units. That also means that as unarmed civilian first responders, we have that direct line of communication to police in those rare circumstances where things do escalate really beyond our ability to maintain a safe scene, just on our own. To that extent, about an eighth of our calls do involve law enforcement in some capacity. The majority of those calls are situations where, based on preliminary call details, and a call was initiated for police. They show up on scene and then recognize as soon as they get there that this needs that behavioral health first response instead. Last calendar year, we responded to 24,000 calls for service in our metro area and only had 150 situations that escalated to the point where we needed support from police to maintain a physically safe environment. So that's 150 Code 3 lights and sirens cover requests out of 24,000 responses for our metro area last year.
And Tim, sorry, I hate to interrupt you. Tim, hold tight. Just because we were all moving so fast, we didn't get to, because we're live on TV, some folks are like, wow, this is incredible. How can I support this program? Tim is in from out of town and from out of state.
That's correct, yeah.
So we really appreciate, so we're trying to figure out how we can expand your kind of model here in Austin. So thank you.
Absolutely.
Now they're on screens, it's hard for people to know that you're far away.
That's right. Yes, I am coming to you all from Eugene, Oregon, and that's where the CAHOOTS program has been based since our inception in 1989. As I was saying, about half of our calls, based on that, initial presenting information, would be categorized as a behavioral health response. But what we have seen is that all of our calls, in one way or another, are about social determinants of health, whether it's related to poverty, access to traditional medical and behavioral health resources, if it's mistrust of public institutions, even just something as simple as the ability to get from point A to point B. Those are all different circumstances that CAHOOTS is able to address. And by being able to come in and address those social determinants of health alongside addiction, alongside housing, alongside behavioral and physical health, we're really able to provide an opportunity for folks to be diverted from the emergency room or from contact with law enforcement and ultimately jail time, simply by being there to really address those needs before they escalate to the point that you see a situation that would require police involvement directly. When we're looking at the successes of our program, what we're looking at isn't necessarily how many demographics boxes can we check. It's really looking at what is our impact in the community, and the best ways that we can measure our impact are in our diversions from the hospital, from the criminal legal system, and our connections to those other services. So when we look at the homeless count in our community, out of that volume of folks who are considered unhoused or housing insecure, how many connections are we able to make to those other resources so that we can empower somebody to really get shelter, get employment, whatever it means to them to feel stable and in a place where they can move forward with their own lives. And finally, just to really kind of highlight the value of this program, we are not responding just to behavioral health calls. Like I said, those do make up the bulk of our responses, but there are so many other things that we do beyond just responding for folks who are experiencing suicidal ideation or another acute behavioral health crisis. We're responding for all of those requests for housing crises, for folks who are really confused and overwhelmed by the list of resources that they might have been given when they went to sign up for food stamps. And how do you call 50 places when you're not even really sure whether you're going to be able to make it to your appointment tomorrow with your therapist? there are we provide wellness checks. We are the first responder for every reported subject down call in our community. And what that means is anybody who's not up and walking around. So folks sleeping in the park, that person who's too intoxicated and is curled up in a doorway somewhere downtown. Those are the other types of responses that CAHOOTS handles in addition to all the mental health calls in our community. And finally, I'll wrap up by just highlighting a little bit on budget. The CAHOOTS operating budget is, including communications expenses, comes out to about $2.2 million a year. We estimate that we are saving our metro area upwards of $20 to $25 million a year. So that's almost a 10-to-1 return on investment based on, the cost of operating our program versus what we're able to save our community in diversions from the jail and from the emergency rooms alone. And I'll keep it brief because I'm sure there are lots of other questions, and I don't want to end up answering some of these questions ahead of time. So I'd love to hear what other folks have to say.
We have two more speakers, if we could, and we'll just go real quick, and then we'll take questions. Ms. Wagner, would you like to cover your part? Get yourself unmuted. There you go.
Did that work?
Yes.
Awesome. All right. Thank you. And thank you guys for the opportunity to visit with you again today. As you know, in 2019, the Meadows Mental Health Policy Institute undertook an expansive analysis of Austin's first response systems to mental health calls for service. And in doing so, CAHOOTS out of Oregon was one of the programs that we reviewed and all of the elements there. But we also took a look at Project Ethan out of Houston, the multidisciplinary team designs that you'll find in Dallas, Abilene, Tulsa, and Oklahoma. We looked at San Antonio, Houston, and others. And the recommendations in our report were actually a combination of the best elements of each of these programs that had success anchored to them, but that were also uniquely developed to fit kind of what is the novel nature of the city of Austin. We looked at everything from the infrastructure of the city, such as demographics and socioeconomic statuses of certain neighborhoods, the travel around town, some of your programs such as community court systems, your community paramedic systems, the ARCH, the unique relationships that exist between integral care, the fire department, and the police department. And actually what that resulted in was a unique program design that was specifically fitted for Austin. And it is unique. It does have a medical forward response that is intended. It's not a law enforcement response at all. And since it is so unique, there's not a lot of data elements that can be tied directly to this program design. However, there is a program very similar to it in Texas that takes into account the statutes, the permissive and the prohibitive statutes in Texas that are associated with both medic and law enforcement services. So let me just provide you a few of those data elements and then go on to answer any questions that you may have about the design. The design that the Meadows Mental Health Policy Institute report includes, like I said, is a medically forward project design. It starts in dispatch with clinical triage, which is critical in any kind of diversion or alternative response to mental health calls for service, because you have to know from the moment of that phone call what is the best and safest agency to send. But then it continues through a community health paramedic approach partnered with law enforcement and social services. And again, that law enforcement partnership is specific to statutes that are here in Texas. But if we look at a design very similar, and we're going to look at the Dallas design because it provides us with an inner city comparison. The Dallas project that is similar but not exact to the Austin design only operates in one zip code in Dallas. And that zip code is very comparative to its neighboring project patrol districts. And so when we look, we can see that since its launch, there have been 1,083 officer hours diverted away from mental health calls for service. And the program's only a year and a half old. That's a savings of about $55,000 a month in total. But again, it's 1,083 hours that police officers have not responded to a mental health call for service. And at a time in Austin where the city was seeing a 30% increase in law enforcement emergency detentions at psychiatric emergency rooms across the city, the project area saw a 25% decrease in those very same psychiatric emergency presentations. Interestingly, because the project does address homelessness, housing vulnerability, substance abuse, quality of life, and mental health calls for service, while Dallas was seeing an uptick in crime, the project area, which is in South Central Dallas, which is a very heavy crime area in Dallas, this particular project area was the only area in the city that saw a decrease in quality of life citations and arrests, as well as quality of life encounters with law enforcement. The rest of the neighboring patrol districts saw upwards of a 33% increase in those contacts, while this program area was seeing a decrease. So when we take the trend and look at it across a lifespan of a year, an implementation of a project very similar to the design that Austin has now would result in 18 full-time equivalent police resources, or FTEs, being diverted away from mental health calls for service, and an average savings of $1.9 million per year with high fidelity implementation. We look at that as, like I said, in comparison to Dallas, because there's not another program design like the one that you have for Austin, and that's because there's not another city like Austin. The infrastructure, the highway design, the dynamics of your neighborhoods, the culturally relevant areas that are within your city that require very specific response. We couldn't just take a program and plop it down in Austin and expect it to work. We wanted to design it around those things that make Austin unique. But with a high fidelity implementation of the Austin plan, we would expect to see full diversion of mental health calls without a public safety element away from law enforcement to the specialized team or to other more appropriate services, as well as similar fiscal returns that we've seen in Dallas. And I want to wrap that up, but I also want to give just a quick support to something that I heard from our first speaker when she was speaking about OGU neighborhood plans and cure violence. As a criminologist, those are some of the highest return gun violence reduction programs that you guys could lay your hands on.
Thank you, Ms. Wagner. Mr. Hofmeister, your video's not on, so I assume that you're there. If you want to just hit the high notes from EMS. Or we'll take questions for Mr. Black and Ms. Wagner. Committee members, any questions? All right, Councilmember Kitchen, why don't you start us off?
Yeah, I just invite Mr. Hofmeister or Andy, if he is here, to speak up. So, okay, so thank you both. This is very helpful. So my question, I know we only have a few minutes, is BJ, as you mentioned, we had the Meadows report, and I know the Meadows report also took advantage of learning from the CAHOOTS program as well as the other programs that you mentioned. So can you just tell us, since we initiated our program last year, and so we've only been doing it for a short amount of time, can you just hit the top 3 things that you think are the most important things for us to accomplish as part of this program to fully effectuate the program?
Absolutely. First, fidelity. Fidelity to the model design is very important with the Austin plan, because it was designed around the specifics of your city and your infrastructure and those things that make Austin unique. But the most important program element would be you've got to have triage, clinical triage in your dispatch. When we looked at the information from the previous 6 years, every single unfortunate encounter with APD was when that officer didn't know what kind of call he was going to. When you can triage that at dispatch and either send the most appropriate resources or send the most informed resources, your chances of a poor outcome are drastically reduced or eliminated. So if you had to pick one area, you've got to have that clinical knowledge and triage and dispatch. The second area would be using telemedicine to the best of your advantage. Austin is a difficult city, and I love Austin. It's a difficult city to drive around. So it's a very difficult city to get resources from point A to point B. But when you have telehealth capability connected to a clinician, and it's the right kind of call to get to, that clinical expertise is on site immediately.
Thank you. I see Andy's available.
Mr. Hofmeister, would you like to add your part?
Sure. Everybody can hear me okay? All right, very good. So here in Austin, we partnered with Integral Care in their expanded mobile crisis outreach team back in 2013. And the way we currently operate is that a 911 call comes in, And if it is routed to EMS, our dispatcher or our call takers begin a standardized triage approach, which is it's a internationally accredited model. And what it does is it helps us determine what kind of call we're responding to, what resources we should send, and how quickly we should send them. So, and then it also helps prioritize. So we're sending the closest appropriate resource as quickly as possible. Right now, when somebody calls in and they're experiencing a mental health crisis, or they're seeking out mental health assistance, at least from EMS, what we do is we go through the standard set of questions, and what it does is it'll categorize it as a psychiatric emergency, and there are different levels of priority to that. Everything from somebody that may actively have a knife and is threatening suicide, to someone that's called and they don't know who else to call, and they're just seeking out assistance, but there's no danger or weapons involved. And so that call is prioritized, and then it's dispatched to our ambulance crews, and the closest available ambulance is set. Now, at that point, when it falls into a certain category, and those priorities are set so that, think of it as in terms of the highest priority one would be where there's like an imminent threat of some kind of danger or threat to life or limb. And then priority 5 would be the one that that based on the way the questions were answered, there doesn't appear to be any immediate threat, and it doesn't require lights and sirens in the same kind of response that something more critical would. For those calls, we actually have MCOT built into our dispatch system, so that MCOT is automatically dispatched and recommended for those priority 5 calls. We do that for a couple of reasons. One, the priority 5 calls, there's no indication of violence or weapons involved, and we don't want to have MCOT started and had just happened, say they happen to be around the corner and they happen to show up to a call if there's any kind of violence or any kind of threat. So MCOT is automatically dispatched. We've provided them radios, and they have a radio channel that they can communicate with our dispatch directly. They confirm their response, and then they respond along with the ambulance crew. It's a bit different in that we don't hear, the way we have it set up is they're not partnered up with a paramedic in the same vehicle. They respond to the call. They may be off doing another call. Maybe they'll be helping with some sort of a follow-up or a response with the police department. But they confirm their response, and then they arrive on scene. Our medics will just confirm that there's no medical necessity to transport to the emergency room. So we'll want to make sure, and we have a set criteria for that. And basically, we just want to make sure that that somebody hasn't ingested something or tried to cut themselves to a point where it requires sutures. But if the patient meets those criterion, then what happens is then we provide MCOT as an option for that particular patient. The patient does have the ability to refuse. The patient can refuse MCOT and can still request transport to the emergency room. And so that's part of the equation there. The other part of that is that when police, if the patient requires an immediate detention, or because of an immediate threat to life or some sort of deterioration in their mental condition, then only the police department, only peace officers in the state of Texas, and certain judges and court staff have the ability to implement an emergency detention, one that can be implemented right now before the patient could potentially leave the scene. So that's an important difference between some programs and then especially what we're doing here in Austin. There are, from the outset, at the beginning of the call, we also have to take into account what kind of indicators there are for things like violence or weapons. That's one of the questions that's standardized in that particular set of questions for that call type. Is there violence, or are there weapons available or involved? And if there are, then we automatically start police department. The police department may be the initial agency that receives the call, and then they may request us for that as well. So that's kind of that in a nutshell. Over the last few months, what we've done is we've also started prioritizing community health paramedics to respond to those calls, and we'll send the closest community health paramedic that's available to those calls as a way to start implementing the model similar to what they've done in Dallas. The only difference is that we just don't have the clinician sitting in the car with us, but we are moving in that direction.
Councilmember Kassar.
So I want to take advantage of the fact that we've got Tim here, except he just saw his screen appear off the screen. Is he still here? I want to take advantage of the fact that we have Tim here.
Yeah, I'm still here.
Oh, hi. You just jumped to the other side of my screen. We've got Tim here and our experts here locally. So Andy and BJ, if y'all could be, keep it really brief as far as highlighting what some of the anticipated program differences might be between here and what's in Eugene. We already heard about the difference on emergency detentions, but what other differences are there? And two, what would it take to, do we anticipate we could get to that level of scale of something like 17% of the 911 calls? So I would like to hear that really briefly from y'all, and then give Tim your chance to say, well, those differences might make sense, or we tried some of those things and we think differently, especially as it relates to telemedicine. I know there's still sort of some debate about what we should or shouldn't do there. So Andy and BJ, this is not in the spirit of having a conflict. It's more in the spirit of, I think we want to learn from each other and know what the actual differences are.
Sure.
Sure, I'll take a few minutes to jump in first. Somebody wave at me if I'm talking on mute. But I think one of the first things that we have to consider is CAHOOTS is an amazing program, but Eugene, Oregon is also a town of less than 200,000 people, whereas Austin is a major metropolitan area of 1 million or more and growing faster every day. And so when you think about the program design for Austin, it has to be the grand scale that Austin is. You have to have the best use of technology. And so incorporating telehealth services from the moment of 911 call to Andy's guys out there in an ambulance to a police car, having telehealth in a police car with over 1 million people and growing every day, you cannot hire yourself enough people to address this problem. So you have to use technology to the greatest extent that you can. We also have to consider that Austin is unique in its demographics. And so you want to make sure that you target your response to the areas where, for instance, when we looked at mental health calls for service across the city of Austin in a 3-year period, there are 3 areas that stand out, which is East Austin, east of 183 off of Loyola Lane, North Austin, south of 183, and South Austin, south of just 290. And so you can't really have a citywide response unless you're going to dedicate, $10 million or more to it that's going to blanket the city. So you need to make sure that you design a system that can respond to your city citywide, but also focus those specific and valuable resources on the areas of most need. And so that's where you would need a hybrid of telehealth and in-person response that would pair a medic with a social worker and an officer for certain areas of the city, but then scale that response down to telehealth and medics or telehealth and law enforcement in areas without such a high call volume. So the design for Austin that you currently have in front of you takes into account the scale, the size, the demographics, and the specific Texas statutes that require a police officer to do an emergency detention. And I think those are the things that are really most different than what you see in Eugene. Eugene's a fantastic program, but Austin's a large, major metropolitan area.
Mr. Black, would you like to add anything?
I think that there, with the city the size of Austin, there is going to be a need for telehealth to be a component of any sort of, more robust mobile crisis response. One of the things that we've experienced in Eugene is that, many of the patients that we're working with are not in a place where they have reliable access to the means for telemedicine without some sort of first responders, as BJ mentioned, coming out to them. Furthermore, there's a lot of our intervention that's informed by the physical environment, where we're having that intervention. Particularly if somebody is unhoused, we are able to facilitate a lot more meaningful interaction with somebody because we're right there with them in that immediate environment. And so that allows us to do things like empathize with them about the weather, but also really just kind of having that face-to-face interaction, particularly in kind of the world that we're living in now where social interaction is very limited. Many of the folks that we're working with are already oppressed and marginalized populations and are being shunned even more. with the level of concern in our community. And that's one place where that telemedicine is going to, and potentially impose a barrier. So as we look at what Austin needs, I definitely think that there is going to be a hybrid, but there really does need to be an eye towards having a new type of first responder that is trained specifically to respond to behavioral health issues, so that we're not in situations where we have a co-response where somebody in crisis is still forced to have an interaction with a uniformed and armed officer. There are going to be situations where somebody has even experienced adversity, with EMS, maybe not in Austin, but, maybe when they lived in Oklahoma, they got roughed up, by paramedics on an overdose call or something. And so we need to be mindful of the past interactions that various communities have had with those traditional public safety resources as we look at, this combination of new first responders and telemedicine access. BJ's right. Eugene is a completely different city, different demographics, different means of getting around town than Austin. And so we're going to need to look at something that's really nuanced and oriented around the needs of Austin. CAHOOTS is not a cookie cutter program that can just be picked up out of Eugene and plopped in Austin. There's a lot we can offer from 31 years of lessons learned. But again, it's going to be, with an eye towards developing something that is really designed specifically to meet Austin's needs.
Mayor Pro Tem?
Just for clarification, Ms. Wagner, did you say that, were you saying that it would have to be hybrid, or you said something about, or it would cost like $10 million, but I may have misunderstood. What was the $10 million part?
The program that is currently designed for Austin is exactly what Tim was describing. It is a program that's designed specifically to meet Austin's needs, taking into account your infrastructure, the difficulty in traveling around the city, the nuances of where your calls happen and the cultural relevance of those neighborhoods, also taking into account the type of responder, whether it's medic, whether it's law enforcement, whether it's social worker with telemedicine. So that program that is currently designed is exactly what he was describing. It takes into account lessons learned and what it would look like in Austin. But to have something that required an in-person response or a dual co-responder that was medic and social worker, or social worker with backup in person all the time, would be extraordinarily expensive. That's the one that I was saying, if you went for an in-person response, that could be up to $10 million or more, depending on the class of the person that you hired per year. The hybrid response that is exactly like Mr. Black was describing, that is in the Austin plan now, is priced out at much less than that, and also has the potential for returning in its first year alone $2 million.
I want to jump in just real quick. I know, Mr. Black, I think you have to leave at 3. I just want to thank you for joining us remotely. The one upside of these remote meetings is that it's much easier to bring in folks who have these different experiences from across the country. So thank you so much for spending some time with us today.
Of course, I look forward to many more conversations on this to come. So thank you all.
Do you have anything else, Mayor Pro Tem?
It wasn't a question, just to make the point. This sounds weird, but $10 million is not a lot, especially when you look at what it compared to, our budget as a whole. So I'd love to hear what speakers think is what would be the system if money wasn't an issue. $1 million, 3 months ago would have been unimaginable, maybe, and I think we're in a different time.
And I think it's all relative to what percent of calls do we think are we diverting for that service. If it's a large percentage of diversion, then obviously the math is different. Councilmember Kitchen.
I just wanted to say, I'll reach out to Tim. I'm very interested in what he's doing specifically for homeless population. We have a host team here, and I'm curious about how those relate to, so I'll reach out to him about that. And I agree with the Mayor Pro Tem that it's the dollars are not what we want to look at first as a limiting factor. We want the design. But I think I hear BJ saying that that's the way she included the design in the Meadows program. But we can think about that. And then finally, I would just say we are all learning how useful video can be. Telehealth and telemedicine has been underutilized for years throughout the country. And it is an amazing resource when you have physical, I mean, it just takes time to get from one space to another space in a big city like ours. And telehealth is a technology tool that that we really need to maximize. It doesn't mean it works in all circumstances. It doesn't mean that we need to use it in all circumstances, but it's a huge resource, and we're finding that now as part of COVID and other situations. I'm sorry, you want me to stop?
I do. Thanks, Councilor Kitchen. Yeah, because you and I have had long conversations about that, both in public meetings. I think we all know how we feel about the telehealth. I want to move on because it's a great pivot into our homelessness and substance abuse conversations. Mr. Hofmeister, Ms. Wagner, thank you so much for joining our meeting today. So I am going to bring up, we've got Matt Mollica and Cate Graziani and Joy Rucker coming into the meeting.
Chair, while we make that transition, oh, we just lost her. Never mind.
Yeah, I was moving them out. Sorry, we're transitioning one place to another. But if you want to daylight something.
I do. I just wanted to know, as we're gathering information, one of the things I'd like to extract is, what do those comparable municipalities have in the way of resources for mental health treatment? I know it's pretty dismal in the city of Austin. So if we're talking about the diversion of resources from the criminal justice system into a different, more appropriate system, I'd just like to know what resources they have on the treatment end. Where are they taking people? And are there other cities who've had greater success that just have more resources in that department?
That's a great point. We all know the statistics of Travis County Jail being the largest mental health provider. That's not going to be a good system for us to be sending people into.
I think it just gives us a really good opportunity to daylight that part of, as we're speaking of broken systems.
Yeah. Mr. Mollica, I have a presentation that was sent to me, but it talks about COVID, and I don't know if that's the presentation you're intending to use today.
Sure, yeah. Good afternoon, council members. It is part of a presentation to use today. The title slide probably is a little misguided, but happy to walk through it. I think Joy and Cate with the Texas Harm Reduction Alliance, we're going to kick us off in sort of a joint discussion here.
All right, so I am.
Oh, no, Matt, we're going to have you go first, so we can tie it all up.
All right, great. Happy to do it.
Are you seeing the screen?
I'm starting to. Not,
Did it come up?
not for me. I don't know. I can work off my slides. I don't know.
Let me do a different. I don't know why this was so hard. It was hard in the last meeting we were in too.
So I'll set the stage a little bit, and good afternoon, everyone. I just want to make sure you all know, in talking with Joy and Cate with the Texas Harm Reduction Alliance, we thought that it would be more impactful to have this discussion together as harm reduction practices and a housing first philosophy for people experiencing homelessness, especially chronic homelessness, is shown to be the most effective way to end somebody's homelessness. And so I think that we, in discussion, in conjunction, when we saw the schedule come out and that was released for this meeting, thought it would be best if we got together and did our presentations and discussions with you all. And ECHO's got a history of working with the Texas Harm Reduction Alliance. Joy Rucker, the executive director, is on ECHO's board of directors. So I just want to make sure I mention that ahead of the discussion.
And I'm happy to be part of this discussion, representing both agencies.
Are y'all seeing the slides?
Nope.
Well, our IT staff's going to have to go back and look at how that works, because it didn't work in the last meeting either. It was very challenging.
All right. Well, sure, and I'm happy to. And I apologize. I put together a presentation because I thought it would be important for y'all to see some of the work that's happening now currently associated with housing high-risk individuals for COVID purposes, but also the folks that are, there it is. And that's the perfect slide to start on right there. Thank you, Councilmember Flanagan. So very, very quickly, I think it's important to recognize when we talk about where we need funding in our community now, and I think we've all had this conversation before, we believe services for people experiencing homelessness and housing for people experiencing homelessness is a place that can be very impactful when looking at the budget and shifting funds around. We have said and stated many times that we think it is very cost efficient to house people experiencing homelessness with appropriate wraparound services. Then and we don't believe that the current model for interacting with people experiencing homelessness, like policing, is not a way, as we all have had this discussion, and it's not a public safety risk to be experiencing homelessness. And so we think that the most effective and impactful way is through housing, and we're going to talk a little bit about that and costs associated with that today. So the first couple slides are just, the first slide here talks about the current targeted population for housing assistance. And I wanted to use the COVID population for a couple reasons. One is that typically if you're high risk for COVID, you are one of the more vulnerable people in our community from a healthcare perspective, substance use perspective, and mental health perspective. And we're going to go over that a little bit more today. So this is the criteria we're looking at in terms of how we're prioritizing the resources we're going to talk about, the resources needed today. So next slide, please.
Mr. Mollica, I don't want to push you too much, but you don't have to tell everyone the full story of homelessness in our community. We're
Sure.
trying to stay focused on the public safety impacts, and there's limited time. So feel free to go quick.
Got it. All right. Well, right now what we've got are identified through the COVID cohort is that we have 971 folks who are high risk based on the CDC guidelines for having a negative impact if they were to get COVID, potentially fatal impact. These are where they're currently residing. Some of them are in our emergency shelter system at the Arch and Salvation Army. Some are in the pro lodges, and some are unsheltered. So the next slide would be great. Sorry, we can move to the next slide, Councilmember Flanagan.
It looks like maybe Councilmember Flanagan's internet is getting interrupted, and so Matt, if you'll just keep walking us through.
Yeah, sure. So the next slide that would be presented talks specifically about race, ethnicity, and what we all know. Most recent point in time count shows that 36% of the folks that are experiencing unsheltered homelessness in our community are Black, African American. We have high proportions of Black, African American people represented in our systems overall here, and we believe that targeting funds for people experiencing homelessness can impact that and have a racial equity impact. All of the funding and housing resources, I want to make sure that we tie in that the services associated with these resources, the much needed services for permanent supportive housing and for rapid rehousing, need to be administered using a harm reduction approach. And what that means is meeting the people where they're at with their substance use and ensuring that regardless of where you're at with your substance use, and Joy and Cate will go into this more, we're going to allow access to housing and we'll provide housing first before we require you to address those issues, the substance use or mental health issues that you might have. So some of these slides, they're kind of hard to talk to, but there are costs associated with them for the rehousing strategy. And we're sort of looking at total costs for folks, whether you're in the pro lodges or not, of upwards of about $24.5 million to ensure that we can house the high-risk folks for COVID over the next year. Again, without the slides, it's difficult to walk through and show you the various benchmarks, but I'm sure the slides can be distributed, and I'm happy to answer any questions associated with the presentation. But we need, essentially for permanent supportive housing, we had 357 people fall into the bucket of need for permanent supportive housing at the total cost of $10.3 million. And we had about 614 households that fell on the intervention scale for rapid rehousing for a total cost of $14.3 million. Another thing I think worth mentioning is that we also ran an analysis on what the investment would need to be associated with the Pro Lodge residents, and we have those gaps too, because I know that's something that council's been focused on. And I think ultimately, I'll let Joy and Cate take over, but the most effective strategy for engaging this population of people experiencing homelessness, chronic homelessness that's existing in our community, of which we have a really high percentage of our folks are experiencing chronic homelessness in our system, about 48%, which is a much higher number than other communities of our size. And that's, I think, because we don't have really well developed harm reduction strategies for engaging that population. So we can go through the slides. I see Councilmember Flanagan's back if necessary, but if not, I'll let Joy and Cate speak a little bit to their work.
Ms. Rucker, why don't you, and Ms. Graziani, why don't you jump in? My WebEx platform crashed, so I'm getting my stuff back put together.
Well, thank you. Thank you for the opportunity to have a conversation with you all today about harm reduction. So I just want to give a brief definition of harm reduction. And harm reduction is an evidence-based model that aims at reducing drug-related harm experienced by individuals and communities. It's also a social justice movement built on the belief that people that use drugs be treated with dignity, and they have the right, if that's what their choice is, to use drugs, that they should not be penalized from any other services because they are currently using. Some examples of harm reduction are permanent housing with volunteer services, as Matt was talking. Housing First is a very successful model that is used across the country, and it's low barrier, and we understand that you're targeting the most chronically homeless people with substance use issues and mental health, and they're not successful in high barrier programs. Medicated assisted treatment is another harm reduction strategy. And for all of us, bike helmets and seat belts. So harm reduction is really a practical approach to a complicated situation. Why harm reduction? It decreases overdoses. HIV, hepatitis C infections decrease, fewer interactions with the criminal legal system, fewer ER visits. Most people are housed and stay housed. Most people connect to treatment, and more people find a path to recovery. Our biggest request is that people want to be connected to recovery services. So we were formed in 2019 as a mobile outreach with TTOR funding from the state. Currently, we offer mobile outreach services that connect people. We connect with people living in encampments who are injecting drugs. We provide them with supplies, and we connect them with recovery, coaching, and treatment if that's what they want. We've been able to set aside in our budget 5 weeks of paid treatment for medicated assisted treatment, and then work with the client, and had been working with Integral Care for sustainable funding, but that funding is no longer available through Integral Care. In the drop-in center, we offer bathroom snacks, access to a recovery coach, place to chill. We haven't been able to be open because of COVID, but we do have people that come by and get supplies from us. And harm reduction is really for the folks that we all know are very committed to continuing to use. So we're not talking about the people that are ready for recovery. We're talking about people that are in pre-contemplation stage in the continuum of the recovery role. So we believe harm reduction is part of the continuum of care for recovery. So Cate?
Thanks, Joy.
Yeah.
I'm Cate Graziani. I'm the Operations and Policy Director. I work with Joy. And I'll keep my comments brief. I know we're running behind, but there are some questions that have come up, even when thinking about 911 mental health crises calls that I wanted to touch on. So when we think about a law enforcement response to substance use, we know that it fails in a number of ways. I think y'all are aware that when looking at our felony possession of a controlled substance less than a gram arrests in Travis County, we're looking at 29% for Black individuals, and about half of them originate from a traffic stop. But also, I want you to know that about 5% of those originate from a behavioral health crisis call, an overdose or a mental health crisis. And in the case of overdoses, I'm sure y'all are also aware that APD has recently refused a donation of naloxone, which is our overdose reversal drug, and it's a critical component of harm reduction. We also know that officers, unfortunately, will watch someone be revived, usually by EMS, either take them to the hospital or follow them to the hospital, and once they've been released, they arrest them on possession charges. So we have a lot of practices in our community that cause harm when we're thinking about substance use, which we understand as a public health issue. Another factor is the sobering center. And I want to also tie it into because EMCOT has already been brought up, I want to tie it in. Law enforcement already has a couple of diversion programs that they can utilize when we're looking at behavioral health issues. One of them being our EMCOT team, and one of them being our sobering center. I know y'all are probably more intimately aware of some of the challenges with those programs, or at least with the sobering center, but I want you to understand that hundreds of people with a mental health diagnosis are arrested for criminal trespass every year. 100% are eligible for EMCOT. Law enforcement does not utilize EMCOT. So they have a diversion program at their disposal. They're not using it. Same goes for the sobering center. We understand that if somebody has a small amount of drugs on them and are intoxicated, the sobering center has changed their policy. They would accept somebody who is intoxicated using an illicit substance. But APD, again, is not utilizing the sobering center, and we could be. And we've been in contact with new leadership over there, and we're very excited. Our organization actually officed there briefly before we moved into our drop-in center. And so we see an opportunity here to partner with the sobering center, with ECHO. Our program is now up and running, and after its first year of completion, where we can really look at the intersections of homelessness, mental health, and substance use using a harm reduction model to just really move that out of the realm of law enforcement response altogether, and think about strategies and solutions that exist in other cities. And so with that in mind, I think a couple programs that I wanted to make sure we talked about, one, obviously the Housing First model y'all are familiar with. There's another program called Direct Access to Housing. And I think both Matt and Joy have firsthand experience with those programs in the Bay Area. But I think as a way to talk about mental health, I think Councilmember Kitchen asked a question about resources. I think we do have a lack of resources when it comes to access to care, but we also, housing is just so critical in a community it's increasingly unaffordable. I think we have to be pairing services with housing. And I think there are so many barriers for folks to access some of even these housing programs, even substance use disorder treatment programs, right? There's so many barriers. We need harm reduction as that bridge, as Joy was saying, really working with folks who are not going to engage, they haven't engaged, and they've probably had bad experiences, right? Maybe they did ask for help at one point and they were told, well, you have a criminal history, so we're not going to allow you in this program. Or if you're high when you show up, we're going to kick you out immediately. There's so many barriers we erect. So I think in moving towards a public health approach to behavioral health issues such as substance use and mental health crises, an expansion of harm reduction programs in collaboration with ECHO and with the Sobering Center would be incredibly beneficial to our community. What harm reduction programs look like in other cities include, extended hour drop-in centers that not only have sort of peer staff, but they also have medical staff that can do wound care. People can take showers and do laundry. And then on-demand access to methadone and buprenorphine, our medication-assisted treatment. So someone could be at the Sobering Center and get inducted, or they could come through our drop-in center and we could connect them immediately to the Sobering Center since they're already operating as a 24-hour clinic. Right now, Integral Care's 2nd Street Methadone Clinic has a 6 to 9 month waiting list, which for somebody who's trying to get off opioids could be a death sentence. We also can look at recovery coaching and connection to housing for somebody pre-release from incarceration. This is something that other harm reduction programs do, right? They act as sort of a reentry peer support coordinator or health navigator. And then I think we need to talk about pre-arrest deflection and using the Sobering Center to bring down those arrests on possession of less than a gram for somebody who is intoxicated. And so those are all the things that we would like to be able to provide to this community. And I'll end there so we have time for questions.
Yeah, and of course we're really tight on time, but I want to thank all three of you. We'll take some questions. I think there's a lot of interesting concepts here as we think about kind of alternatives to a enforcement response. And I could hear as you all were talking how we need to be engaging the county in these conversations as well, because it seems like a lot of the financial savings to taxpayers might actually happen on the county side with relationship to jail. We may not see those cost savings because we're going to be shifting resources around to provide services in new ways, but there might actually be savings on the county side. And so we have to be thinking about this stuff holistically. Questions? Councilmember Kassar.
So we have the budget coming out on Monday. I'm sure y'all will email the council what these things would cost as far as reallocating funds from enforcement strategies to prevention and harm reduction strategies. But can you give us really quickly, top line, some costs for what it takes to house people, what it takes to get people the treatment and care they need at the scale you think we should do?
Yeah, so I could take the first stab at this. So if, just looking at the first cohort of folks, there's 971 folks we identified as being very high risk that are unsheltered or in the pro lodges right now. We know from our point in time count that a self-report point in time count that we see around anywhere between 60 and 65% of the folks reporting a substance use disorder, that are experiencing unsheltered homelessness. We've got to house those, 971 folks, about a $25 million annual cost associated with that, 25.6, and that's to bring housing and supportive services like the harm reduction services Cate and Joy mentioned in housing, and to get folks engaged off the street, engaged with our, with our harm reduction strategies and into housing. And so there are other costs associated with some of the diversion tactics that Joy mentioned and Cate mentioned that they can speak to, but that's the budget associated with housing and providing harm reduction supportive services to that population.
And that's 25 million more increase above and beyond what we do now.
Yes, and it's also above and beyond the ESG CARES Act funding that came into the
and that's 25 million in O&M and recurring funds per year.
Correct.
So just to high level budget numbers, thinking through some of the things that I listed towards the end of my comments, right, about expanding access and hours at our drop-in center. We'd also want to be able to expand our mobile outreach services. That's a big element of how we connect with people. Almost everybody we meet through going to encampments and building relationships there, providing supplies and education. And so we want to really be able to amp those up. And so we're looking at to be able to expand our drop-in center, expand our mobile outreach, and expand access to methadone. So there's no waiting list for somebody who wants to get on treatment. We're looking at about $1 million.
Councilmember Kitchen.
Thank you. So Matt, what would be the additional cost for rapid rehousing and permanent supportive housing dollars? In other words, the dollars it takes on top of the 25 million to help people move from housing to permanent housing? Or are you including that in your estimate of 25 million? My guess is you're not.
So the $25 million will house the 971 folks we identified as being the highest risk from a healthcare vulnerability standpoint. That's not the total number to get to, obviously, to get towards functional zero or the actual need in our community based on some of the modeling we've done. That number is close to $126 million. So does that answer your question, Councilmember Kitchen?
I think so. So the 25 million you're including is not for shelter housing, it's for permanent housing for people.
Correct.
But
Yes.
all the services it takes to help someone get to permanent housing, whether those social services, mental health services, harm reduction services, or first month rent. It's the whole thing is what you're counting for.
So for those 971 individuals, it's that amount of money for those folks. That's correct.
Okay. Yeah. Okay. This is great. Thank you very much. I can talk to you offline, but I'd also like to delve into what it would take to get us to functional zero. So.
Yep. Love to talk about that.
And I think there still is some good conversation to be had about how standing up some of these additional services can help us reallocate where we're currently sending policing resources, because we're only looking at enforcement actions versus compliance or protection or supportive actions. You know, that's just obviously the whole work, because we can't invent money out of nothing, really.
Councilmember Flanagan, can I make one quick point? I think one of the things that I want to really harp on is the harm reduction services that Cate and Joy are talking about. If we're able to get those types of services into our community, ultimately we will be driving down the cost of housing folks long term. Like, those are the type of resources where we can divert people out of the system more quickly. It's the tourniquet on the faucet, on the hose of folks coming into the system. Both of these, because we failed on for folks for so long, both of these investments are needed. But we need to also be really considerate of how we can start to divert folks through harm reduction practices on an outreach level out of our system more quickly. So I want to make sure that we highlight that part of the discussion. They're much needed resources as well.
Thank you.
Mayor, did you have something?
Just wanted to indicate support. I was enjoying the conversation. This is
great.
Thanks, Mayor.
I muted myself. Let's move on. Thank you so much, Mr. Mollica, Ms. Rucker, Ms. Graziani, for your participation today. We need to get into our family violence conversation. So I'm going to bring in, see if we've got everybody here, Kelly White and Melinda, there she is, and Courtney.
Good afternoon.
Hello, hello.
Hi.
We can see and hear you loud and clear. Ms. Santana, Ms. White, you want to test your audio? Try one more time. Hit that mute button one more time. There we go.
Okay, so now I'm unmuted?
Yep, sound great. Ms. Cantu, are you there?
I'm here. Can you hear me now?
We can hear you. Your video is not coming in yet, but if you've just turned it on, it might take a second. So y'all have been in. Oh, great, we can see you. So y'all have been following along the whole time, so we don't have to give you the what we want to hear from you. Ms. White, Ms. Cantu, why don't you all start, and then we'll have Ms. Santana go.
Okay, I'm going to start. Thank you for having us here today. I am Kelly White, co-CEO at Safe Alliance. I'm going to start, going to kind of give an overview, and then I'm going to turn it over to Melinda, who's our Vice President of Housing, Healing, and Support Services. So I want to state up front that this is a huge issue. Family violence is enormous. The needs are enormous, and there's plenty of room for multiple strategies, and I think you're going to hear about some multiple strategies here today. This morning, SAFE also sent you an overview of SAFE's position on police and public safety in Austin, the city of Austin. And that short paper will provide a lot more detail on SAFE's position regarding our beliefs and recommendations for how the city of Austin might consider moving forward in thinking about public safety through the lens of creating peaceful, safe, and equitable communities. And it strikes me as you talk about this that we already do massive alternatives to law enforcement. And the reality is that we just need more. What we have is so horribly, it's just not enough. Law enforcement and child protective services confirm over 11,000 cases a year of family violence in Austin. And the actual number we know is much higher because abuse lives in the shadows and it thrives in secrecy. SAFE served 6,628 clients in 2019. 49% of which were Hispanic, Latino, 22% white, 16% Black, African American, 2% were Asian. We also provide services specifically for people who are deaf and people with disabilities, and we are part of the City of Austin, Travis County Family Violence High Risk Team. More than 50% of our direct service staff are bilingual, and our senior leadership team and board of directors are representative of the very diverse community that we serve. We currently offer a myriad of services. I'm not going to give you the laundry list, but it includes court-based legal advocacy, healthy parenting, counseling, rapid rehousing for youth and families experiencing homelessness and abuse, permanent housing through a low-income housing tax credit project, 24-hour chat, text, and call, Safe Line. And what I'm really going to talk about today is we have a 105-bed family shelter. SAFE has fewer emergency shelter beds today, available today, than it had 15 years ago. Almost all SAFE programs operate with lengthy waiting lists, and the status quo just isn't acceptable. In 2019, the board adopted a new strategic plan that prioritized increasing emergency shelter for survivors of family violence. And one advocate used the words that said, what this really is a murder prevention program. That's correct. That's what it is. We weren't meeting the need pre-COVID, and the situation is now dire. 5,687 people have called us since COVID started, but 15 to 20% are between 850 and 1,100 of those calls rate as moderate to high lethality as the risk that's scored on the Campbell Danger Assessment. The assessment is also utilized by APD because it was designed for use by law enforcement and domestic violence programs. Our SafeLine director is certified in doing that assessment. As an example, day before yesterday, we had 4 families, that's moms with children, and another 5 single women with CDA scores of 18 or above. That is high lethality risk. We also had another 12, 6 women and 6 families that were at a moderate lethality risk. Every effort is made to get these individuals what we call behind the gates. And if we're not able to, we do extensive safety planning, and they are offered alternative referrals. But behind the gates is an intense focus on safety. It's important. And also the attention to case management and the support services is equally important when we consider long-term change, about not having to address the long-term homelessness, of which family violence is a huge issue. And rarely is it a matter of nights of shelter and all is well on their way. I think it's most of you know that I was once in a shelter. I went with my 2 children, and I know that I was the exception. I knew it then because I was white, I was middle class, I was college educated, I had reliable transportation, I had connections, a good job, a home, and really importantly, because of all that, law enforcement believed me when I said that I was going to be killed. I only needed to be in shelter for a few days, and I was able to get in and get out. I didn't need all those services, but I was the exception to the norm. And most people, that is not the case. So we've been working really hard to create services to address those programs that we see, that what we call our murder prevention program. And I'm going to turn it over to Melinda to talk more about that.
Thanks so much, Kelly. Can everybody hear me?
And see you.
Oh, good. Okay. So I just want to say that thank you so much. Part of what we really started to do as we moved into this pandemic is that we knew that survivors were going to need additional support, and we knew that we needed to address precautions and social distancing, as well as additional sanitation, specifically in our congregate care settings, which is the behind the gates programming. So what we really started to do as an organization is really start to think about how we can get some of those more discrete spaces for immediate shelter. Now, over the years, we've actually worked closely with APD and Victim Services and the hospitals to immediately serve high-risk survivors. As most of you know, we are in our shelter, and I've been there since 1990, almost always full. We're constantly trying to, I always say it's a chess game of figuring out where people are inside, where they can go, where those are outside, how they can get in, and trying constantly to think about overall safety. So we really were starting to think about how we identify those and how APD and the hospitals were going to figure out how to get people maybe not back home and into our shelter. If we weren't able to do that, we worked with them to identify hotels. Now, what I found out over the course of the years is that many of those survivors were really scared, they felt isolated, and they were frightened and concerned, and particularly if they had children, it was really difficult for them to go from leaving a very, very scary situation into a hotel where they might have felt isolated. So as I was thinking, and as our shelter leadership was thinking, and our executive leadership was thinking, what we really started to do is think about on the back end of shelter, what years ago we used to call transitional shelter. We started to think about that model where we had people who had been in shelter who had gotten some supportive services, who maybe had gotten protective orders already in place. They were much safer, but they were waiting to go into the next safe place. A lot of times that is housing in our community. And I just have to say, just the information that Joy and Matt talked about, and Cate talked about earlier, that really looking at housing first and peer support and harm reduction, those are philosophies that I've grown up around, and really are very well suited to survivors in this community. And I would say that so many of the people in our community who are homeless are also trauma survivors as well. So just thinking about that model, we were looking at how we could work with maybe one hotel. And we had a few things that we really wanted to take into consideration. We wanted a single point of entry because we know danger levels. We wanted a place where children would feel comfortable and safe. We wanted close access to public transportation and food. And we wanted staff to be able to work with a team of staff in a hotel where they could work collaboratively and do some training and support, because we know just the myriad of issues and services that survivors come with. So what we decided to do was staff this particular program, the Shelter Away program, with dedicated employees that would be responsive to the adults and the children staying in the Shelter Away program. Really, I am a children's advocate by heart, and one of the very most important things that I know is that kids can sometimes feel forgotten and also have such huge fear, and they're sometimes not comfortable talking to their parent about it because they've made these huge steps in trying to get safe. They don't want to additionally burden them with their own concerns. So we wanted to put a lot of resources to those kiddos. So our Shelter Away program is set up to really offer hotel stays in one specific hotel in Austin, but we wanted to make sure that the families who were moving over there had a lower lethality risk. We also wanted to make sure that they had a housing plan. As you heard from Matt earlier, there's a lot of advocacy and support that goes into getting people long-term, safe, affordable housing in our community, and going from a shelter program into housing can be quite difficult, and all of the other resources that people may need, accessing mainstream benefits. And sometimes for people who've been so isolated within their domestic violence situation that they have no idea what's the first step. So all of that advocacy, we wanted to make sure that that piece was done before these folks moved into our shelter away program. So lower levels of risk, and also really these folks had an active housing plan in place.
Great. Thank you, Ms. Cantu. I want us to keep moving along. Ms. Santana, why don't you take a minute or two and talk about your program, and then we'll do questions.
Absolutely. Thanks for having me today. I just wanted to share some information about the alternative models for policing. I think that's what the call is about. But for Survive to Thrive, over the past 7 years, we've been working specifically with displaced and homeless victims of various forms of domestic violence as a public health issue. And we've noticed that police officers in general, and in our interactions with them and conversations with them, we've done focus groups with them, they're uncomfortable in dealing with victims that they encounter when they go on these calls. We meet regularly with law enforcement, and they cite that there's a loss of man hours when officers have to drive from point to point and there is no place for these victims to go. To quote retired police officer, police chief Todd Smith, he says, we can spend up to 8 hours easily in a car just looking for a safe place for victims to go because the shelters are full. The goal of APD in these calls and on the scene is to mitigate any danger that the victim might be facing and to remove the vulnerable party from the scene. So we've enlisted the assistance of victim services with APD and the CRT, the crisis response team, to further that assistance for our clients. And we believe that we could reallocate some of the APD budget to truly be beneficial in assisting victims in the following ways. The allocation of more budget to hire more victim services counselors. So just moving that money over to the victim services counselors group. There are 13 currently, and they're dealing with all of the lethal cases that come into APD. So they are going to traffic, fatalities, child abuse, trafficking. If we could have a dedicated response team just for domestic violence and family assault, that would be great, and sexual assault. Additional funding for caseworkers, for supporting NPOs and service providers for victims as they are placed in a safe environment. So once they're placed in that environment, I think that they mentioned that this isolation that victims feel, when you have case management and you have connection, either through phone calls, through the virtual ways that we've had to do it since COVID-19 became a thing, clients are more likely to move forward. Also, additional DVSA training for APD officers as they respond to these calls. The methodology that these officers are using is, in our experience in the last 7 years, it's inconsistent, and sometimes it puts our victims at risk. Also, I feel like there is a lack of technology that law enforcement can be using. We are working with APD right now to create a tool where they know where available safe spaces are. I don't necessarily agree with the idea that one hotel is a smart move. A safety net of hotels that when a client might be found in one hotel, they can be moved to another hotel on the other side of town is vital. We've had that happen several times where a client would be in a hotel and now we have a safety net across the city. This platform was created and it's available now to APD and a pilot so that they can find available safe spaces. And since we've been doing these different technologies and different tactics since April 13th, we have had 86 interactions with law enforcement where we will be able to quickly place DVSA clients and trafficking victims within an hour. We've had over 1,000 calls to our phone bank and our offices for assistance. We've placed over 100 families in our safety net of hotels across the Austin area, and we've assisted 18 of those families to move into permanent housing during COVID-19. So I agree with Tim. I also agree with Matt. The housing first option is the best option. Clients, once they're safe, are looking for a way for them not to have to go back to their abuse. And we've modeled a lot of our programming to the Rose Andom Center in Denver. where they do have that housing first option. So I'm open for the more conversations about this, but I feel like the impact of all of this comes from a coordinated effort of the City of Austin, APD, Travis County, the service providers, nonprofits, local shelters like SAFE and Hope Alliance and Round Rock, and the 1,200 available hotel rooms made available through the Austin Hotel and Lodging Association. More funding to address this, and this way we're all collaborating instead of looking for one option, would actually provide an exponential impact for the whole city.
Thank you, Ms. Santana, and thank you, Ms. White, Ms. Cantu. I think it's a great kind of layout to see this suite of solutions that are necessary for such a complex problem.
Absolutely.
And it'll be some good work to look into the types of diversion services that have been provided in the past to have it kind of quantify how we may have walked down this road a little bit already, and then learning more from our APD folks and others about how much time they're being spent on things that maybe didn't have to be officers spent on those things, even if it's not as much of a first response alternative, but maybe it's instead of a 4 or 8 hour call, it now becomes a 1 hour call, which then allows us to better use our police resources. Any questions from council members? Councilmember Kassar.
Thank you for sharing, and I didn't know that we are at fewer shelter beds at SAFE now than 15 years ago. So thank you for sharing that. As far as budget numbers, because we have the budget coming out on Monday, what would be a significant and meaningful investment for getting public safety for a lot of your clients, a lot of our neighbors that are experiencing family violence?
I'd like to answer that question. In the model,
Ms. Santana and then Ms. White.
Yes. And the model that we're currently using right now, we know that once our clients are placed into the hotel, they normally start our program at about $2,500. That's to get them placed, to take care of them for probably a couple of weeks, provide food resources, counseling support, and case management support. Once we're trying to rehouse them, it's between $3,000 and $5,000 because that includes all the reletting costs, all of the associated moving fees, all of the things that would come up as a result of somebody trying to move. In total, we look at the total cost for that budget to be close to $5.6 million. And we're looking at providing that for about 300 families a year.
Ms. White.
So we could increase, and in looking at it, our initial plan would be that we would be able to increase our shelter beds by through a hotel. And mind you, beds it fluctuates because it has to do with families. And so we generally factor in an adult with 2 children, so we could increase our shelter beds by about 90 shelter beds a year, 90 shelter beds. We could go up by 90 shelter beds, and I haven't actually figured out how many people that would be in a year, but we could do that for about $1.2 million a year, so $110,000 a month.
Thank you. And that would be the operating cost with the city making a capital investment in the building.
Correct. That's we would not be doing the building. And let me just say, I mean, we talk about shelter away, but we will not be able to continue that unless we have some funding for it, which we don't have. And so we're looking at that as it's been really successful and wonderful, and we may not be able to continue it.
And what is the funding gap on that?
It's about, since we're doing it at a decreased rate right now, I don't want to say an amount and have it wrong. Maybe Mollica. You know, of interest, and just to add in, because we talk about rapid rehousing, we have 3 large HUD grants to do rapid rehousing. One where we don't have one where we are very much partners in the youth rapid rehousing with LifeWorks. And we also then have 2 domestic violence rapid rehousing grants for homeless families that have experienced abuse, and to do rapid rehousing for them. And each of those grants requires somewhere around a $400,000 to $500,000 match. That's also a challenge for us.
Yeah. And right now,
understatement.
Yeah, right now at Shelter Away with just 5 to 10 families, it's about $8,000 a month.
Yeah, and to be clear, right, we're not doing budget work right in this moment. So we're just trying to get council members and the public a sense of scale. The budget process is going to be a complicated one, given pandemic, given tax caps, given all the things.
If you could get the budget, if you could get these numbers into the budget by Monday, we
would do a happy dance.
Courtney, Ms. Santana, do you have something to add?
I will say that the high lethality cases should be going to the shelters. I totally and completely agree with that. There are times where we have clients that, because of their situation, they should totally be inside of a shelter, inside of the walls. But for those who don't need that, it's really important for us to be coming up with innovative strategies for where they should be. And we should be collaborating and partnering to create that safety net for those clients. Right now, we can't really talk about budget because we're not talking collaboratively with all the service providers that provide all of those resources. So
it's been a challenge in a lot of areas. We've had that challenge on homelessness. We've had that challenge in workforce development, and we're all trying to figure out better ways to kind of streamline the ecosystem around every community challenge. Any other questions? We have one more set of panels or officers who are going to come join us. Councilmember Harper Madison.
Well, fortunately, in the interest of time, Ms. Santana just answered two of my questions, especially as it pertains to collaboration with service providers, plural. I just wanted to, I've heard somebody say earlier on the importance of collaboration between service providers, plural. And so I just want to make sure that we're open to exploring what all the options are. And I appreciate that. I think Ms. White might have said, or maybe it was, I'm sorry, I forget who said it, but something about the ecosystem that surrounds this particular topic and subject matter. So I really appreciate that we're looking at it, sort of comprehensively. And then the other question I had was, Ms. Santana, you said something that really piqued my interest, and because we're not talking budget today, I think I'll ask you offline what you think that number looks like, in which case I won't ask what the number is, but I will ask, from a practical application perspective, what does making certain that public safety folks have the appropriate DV and SA training? Like, what does that look like? As we're doing an audit around Training Academy right now, what should we be paying attention to? Are there other cities who are getting it right? Just any, guidance you can offer us there.
Absolutely. Thank you. We worked with the Rose Andom Center in Denver and did a pretty comprehensive study of their program. Literally, they have a police substation inside of their building. They work very closely with law enforcement, and on much of the trainings that other staff members are receiving, so are these law enforcement agents, the department does. So they're working very, very, very closely. I don't think that there's enough training, and I will go and get those numbers for you because it's so inconsistent from officer to officer how they are handling clients. I think if they had more consistent training that was black and white and then passed off the clients to victim services for more handling and then off to service providers, they would be a lot happier about that as well. So I will get you that information. I'll be happy to.
I appreciate that very much. It makes me think about the EMS presentation earlier when they made mention to dispatch disparities. And I would venture to guess that it's the same across the country. So I think the closer we can get to sort of a unilateral expectation around training there, the better off we are. Thank you all for your time. I appreciate it.
Yes, thank you, Ms. White, Ms. Cantu, Ms. Santana, for your time today. We're going to move on to our last set of panelists.
Thank everyone.